Thank you very much, Dr. Hertz, for inviting me to comment on a controversial topic, both politically, clinically, in regards to physician-assisted death. I have been, for the past 15 years, doing the psychonephrology clinic each Thursday about 4 or 5 hours, seeing between 8 and 12 patients. One Thursday I do the dialysis clinic, and over the years I've seen over 500 patients. And on another Thursday I do the kidney care clinic, where I've treated individuals with psychiatric conditions over the years. Some of my patients are still alive, although it's been over 10 years. Some are still alive, and I'm still continuing to see them. So what I wanted to do today was give you a clinical flavor of the types of patients that request stopping dialysis. So I have 3 cases. I'll present them briefly. 2 in which physician-assisted death actually materialized. This was back in 2008-2007. While the 3rd patient, recent patient from December 2015, expired as a result of cardiopulmonary failure on our medical ward. For the first 2 patients, I had the opportunity to assess and treat them over weeks to months. During this period, many psychodynamics surfaced. As I am a psychoanalyst, I'm very interested in what drives people's decisions, their minds, and their behaviors. Some of which were explored in greater depth than others. And in keeping my presentation to the 5 minutes I promised Dr. Hertz, I won't be able to get into much depth in regards to the common themes that I encounter, but I will talk about some of them so you have a good idea what my part of the work involves. The patients that I've treated, the treatment has included medication, psychopharmacology. I've treated them with antidepressants, with benzodiazepines, and with several atypical neuroleptics, alongside psychodynamic psychotherapy, exploring the roots of their affective states and conflicts. The common themes that have emerged have included losses at different levels, beginning with childhood losses, adolescent and adulthood losses. Losses involving object, which in psychoanalysis we refer to as meaningful others, and the loss of self-function over the years. As well, the realization of there being no hope for them and no way to restore their pre-morbid psychological and physical functions. So a prevailing sense of helplessness and hopelessness with all 3 patients. 2 of my patients are ladies, both in their early to mid-80s. Patient A suffered from bipolar disorder with a history of some 50 years, 40 of which she was treated with lithium carbonate, the cause of her kidney damage, and consequent end-stage renal disease. She was a college physics professor, never married, and several textbooks to her credit at the high school and university levels. She had no children. She came to my attention in 2008, following a year of treatment on Seroquel alone, as I could not give her lithium. She was stable with no evident psychosis, mood instability, or cognitive dysfunction. She repeatedly came across as being mentally competent, which is something that we always look for, to consent to treatment as well as the withdrawal of treatment. Following weeks of repeat psychiatric assessments, I decided that she was competent enough to consent to the withdrawal of hemodialysis. She was admitted to a medical bed at our former church site, Humber River Hospital. All life-sustaining treatment was withdrawn, and within a week she slipped into a coma and expired. She was, while conscious, aware, and given the opportunity to reverse her decision and be put back on hemodialysis, which she did not want. She did not change her mind. She died peacefully. My second patient was an 85-year-old single childless woman whom had been on dialysis for some 6 or 7 years. She was highly educated with no previous history of any psychiatric illness. However, she had suffered from periods of depression, reactive depression, because she had lost all of her loved ones and was left all alone by herself. Free of major depression or cognitive decline, she decided to stop dialysis, stating for the main reason that she had no one left to love nor be loved by. My third patient, the second patient also died quite peacefully within 10 days or so. My third patient was a 38-year-old gentleman with type 1 diabetes mellitus, end-stage renal disease on dialysis, diabetic retinopathy, and neuropathy, which were quite bothersome. He became disenchanted with his life. He was envious of his younger siblings, his younger brother's his younger brother's marriage was coming up, and the patient was quite envious of this, along with the good health and success that this sibling enjoyed. He began voicing his desire to stop dialysis in December of 2015 when I first saw him in psychiatric assessment. He expressed much ambivalence about committing suicide, and that was because he was of East Indian background and he belonged to the Hindu religion. He feared reincarnation and karma and coming back as a lowly animal. In fact, he said, what if I return back as a rat? How do I cope with that? He was on antidepressant treatment. He changed his mind twice and decided to continue dialysis, mainly driven because of his religious beliefs and his fear of letting his family down. Perhaps fortunately for him, given his many illnesses and morbid conditions, he, on the medical ward, about 6 weeks ago, he coded. He expired of cardiopulmonary failure while being investigated for pulmonary embolism. So the one common dynamic over the years that I have observed with patients is the loss of their loved ones, especially in the geriatric population. They look back, their spouses are gone, their siblings are gone before them, sometimes their children are gone before them. So having no one to love or be loved by has been a very common psychodynamic over the years of my practice. So with that, I will finish and gladly take your questions later on as far as my role in working with renal patients. Thank you.